My name is Jeong, the Department of Surgery. Today, we're going to talk about, with significance, the use of elastographic system in checking axillary lymph nodes metastasis in breast cancer surgery. Again, axillary lymph nodes metastasis is very significant in breast cancer, which is why axillary lymph nodes are checked in the course of surgery. The current surgical treatment trend of axillary lymph nodes metastasis goes contrary to the conventional total resection of axillary lymph nodes, as the resection of axillary lymph nodes is preceded by inspection of sentinel nodes. While surgical treatment is underway, resection of axillary lymph nodes will now take place only when metastasis is found in sentinel nodes. As illustrated in the figure, during the surgery, a couple of sentinel nodes are taken for frozen section examination for detection of metastasis. Resection of axillary lymph nodes will be determined under consultation with the pathologist standing by. The aforesaid frozen section examination takes about 30 to 40 minutes during the surgery. Despite the textbook 20 minutes, you know that the examination lasts 30 to 40 minutes. It happens from time to time. The examination addresses cost the patient, not to mention the standby time during the surgery until the examination is complete. Some surgeons omit frozen section examination because of this. This especially is the case outside Korea, as the surgeons out there barely conduct frozen section examination during the surgery. Now we're going to talk about shear-wave elastography to check the stiffness of tissue, which matters based on the fact that elasticity differs between cancer tissues and normal tissues. We know that cancer tissues are more elastic. Therefore, using shear-wave elastography is quite useful in telling malignant masses among benign masses. Tissue elasticity is useful criterion in determining metastasis to axillary lymph nodes. Benign masses are viewed elastographically like this. The masses are in breast, not axillary lymph nodes. If benign, nodes look less elastic. Take a look at the cancer tissues in breast within the region of interest and see they are highly elastic, being the basis of cancer diagnosis. So we hypothesized like this: metastasis to axillary lymph nodes can be predicted with advanced accuracy when elastographically detecting breast cancer. And it is some of the most simple means of predicting axillary lymph nodes and may effectively replace frozen section examination. There are a number of previous studies showing that the elasticity of axillary lymph nodes varies before removed during the surgery. On the contrary, only few previous studies discuss the elasticity of axillary lymph nodes as removed during the surgery, which is what we thought useful in determining metastasis. So we planned resection of sentinel nodes during the surgery to elastographically assess the elasticity in ex vivo settings also during the surgery, based on the hypothetical expectation that the elasticity is an effective predictor of metastasis to lymph nodes. For this study, we've got a total of 228 lymph nodes collected out of 55 patients. 18% out of which translated into 41 lymph nodes were confirmed to be metastatic. Take a look at the characteristics of the patients, about half of whom had metastasis to lymph nodes. Also, take a look at the figures A and B for metastasis-free lymph nodes and the figures C and D for metastatic lymph nodes. Calculated out of the regions of interest of these figures are mean stiffness, max stiffness ratio of tumor tissues to normal tissues. When it comes to the lymph node size, the sizes of metastatic lymph node and metastasis-free lymph nodes are quite different, as are mean stiffness, max stiffness, and the ratio of tumor tissues to normal tissues with statistical significance. Both stiffness indices, mean stiffness and max stiffness, are correlated with the metastatic size, as you can see. Meanwhile, on the AUC curve, AUCs for all indices, node size, mean stiffness, max stiffness, ratio remain high at or above 0.8, meaning that the indices are viable metastasis predictors. Now, the univariate multivariate analysis. The result of the analysis had it that there were 3 viable multivariates in predicting metastasis, which are node size, mean stiffness, and ratio. In conclusion, we can say that the shear-wave elastography shows significant correlation between variates like node size and elasticity and indices like mean elastic stiffness, max stiffness, and ratio, backing the shear-wave elastography viability of predicting axillary lymph node metastasis. Next, we've worked with the nomogram, which is quite viable in terms of availability, among other methods, to predict metastasis in clinical settings. As an easily accessible metastasis prediction model, we've developed the specific type of nomogram based on several ex vivo shear-wave elastograms. First of all, we've used a total of 228 lymph node elastograms. More specifically, the node size, the mean stiffness, and the ratio to develop the nomogram that predicts metastasis, followed by validation in 80 different patients, using a total of 217 sentinel nodes, 17 out of which were found to have metastasis. When we take sentinel nodes and test, we barely find any metastasis to axillary lymph nodes, as viewed in the subjects in training cohort, which affected the result a bit. As you can see, while lymph node metastasis is found in about half of the subjects in development cohort, which consists of 55 subjects, mere 13% of the subjects in validation cohort had the metastasis, which I think affected the result a bit. As for node size, mean stiffness, ratio, these indices were higher in subjects with metastasis, with statistical significance, of course. It is also to note that when there were less metastatic tissues, the size of metastatic tissue was smaller. And, as for node size, the p-value had no statistical significance, while significant differences were found between mean stiffness and ratio. So, based on those 3 indices, we developed a nomogram that produced results based on each of these indices, node size, mean stiffness, and ratio, coming up with the total point, meaning the predicted probability of metastasis. In the example, the total point of 38 translates into 92.2% probability of metastasis, which is, yes, highly likely. In the subjects in training cohort, AUC was found high at 0.856. AUC was also high in validation cohort at 0.791, although slightly lower than that in training cohort. Explained so far backs the idea that our nomogram effectively predicts metastasis to lymph nodes and is a viable option for use in clinical settings, which is why we hope that the nomogram ultimately replaces, or at least in some cases, serves as an alternate means of frozen section examination conducted during the surgical process. Efficiency in cost and time will then certainly follow. In the beginning of today's session, I told you that the cost is the major factor for frozen section examination, not to be conducted as a common practice outside Korea, in which cases our nomogram may ease burden of patients cost-wise and gives these patients a viable option that effectively alternates the conventional frozen section examination. We've applied a patent for this, and we view that our nomogram gives an insight at the site of surgery as to deciding whether or not frozen section examination will be needed based on the nomographic results.